So let's go. So welcome everyone. Thank you for being there. First of all, I want to thank everybody involved in this webinar, the people that helped in the committee to make that happen. And thanks Darren, because he accepted the invitation rapidly and without hesitation though. So that's great news. So for tonight, like I said, there won't be any handouts. I'll give the word to Darren so he can explain how we will function tonight.
Thank you very much. So thank you, Loïc and Physio Fribourg for the invitation to provide this workshop this evening on long COVID, specifically for physiotherapists. So I'll introduce myself first before introducing how tonight will run. So my name is Darren Brown. I'm a cisgendered gay white man. I live in London in the UK. I'm of mixed English and Irish heritage. I'm a physiotherapist. I work both clinically and academically in the fields of HIV and cancer. And I contracted coronavirus in March 2020 last year, and I continue to live with long COVID. So I'm a person living with long COVID. And the purpose of this workshop tonight is to provide all of you with a unique opportunity to ask the questions that you may have wanted to ask about living with long COVID, specifically to me as a person living with long COVID, but also as a physiotherapist. So hopefully all of you that have registered for tonight's webinar would have received the emails, as there are free courses that are available that can support you in participating in this workshop this evening. And I'll make sure that I put the link into the chat box on how to access that if you've not already done so. This is a Physio Plus course. It's a free course. It's a couple of hours long and it goes through all of the basics. So the way tonight's going to work is, as I said, you have the opportunity to ask your questions using the Q&A buttons at the bottom of your screen here. So if you've got a question, ask it. Ask any question you want. And what we'll do is we'll have a discussion about those questions. But I'm going to start by giving a brief introduction to my journey of living with long COVID, so that you can get an experience of one person's journey. Before I share that journey, I do want to make it very clear that this is my personal experience and mine alone. And anything I say about my experience may be similar, but also may be different to many of the hundreds of thousands of people and millions of people now living with long COVID around the world. So, as I mentioned, I contracted acute coronavirus in March 2020 last year, and very likely through my job role working in a hospital, because I work in an acute hospital in London. I presented with all the usual clusters of acute symptoms that I think most of us are familiar with now, the usual acute coronavirus symptoms. I was unwell, I was off work for 10 days, and then I returned to work. And I returned to work full-time. And in fact, I was able to work full-time for 6 months. During that 6-month time period, I had some lingering symptoms. And those symptoms included fatigue or exhaustion, some breathlessness, and also some challenges with my coordination. I kept tripping up the stairs when I was using the stairs. However, I felt that I was recovered or recovering from coronavirus. And because of the nature of working and responding to the global pandemic, and I was redeployed to various different settings in the hospital, including intensive care, I was really not sure what was exhaustion because of the work we were doing and what was exhaustion possibly because of what was happening. I'd had an infection before. So as a physio, I tried to rehabilitate myself, and I started to try and do some gentle exercises as we would. I'm normally a physically active person, and I tried to participate in those. And over that 6-month period of being in work, I noticed that the fatigue was starting to get worse. And I couldn't quite figure out why or what was happening. It didn't make sense to me, and I didn't understand what was happening with my body. And one weekend, it felt like I'd just crashed. I went for a long cycle, went for a walk, and by the Sunday afternoon, I struggled walking. I couldn't process information in the supermarket. And in fact, I got to work and I was sent home from work because I just wasn't processing being properly. I wasn't able to walk or concentrate. And I was signed off work in September last year, originally for a week, but I was bedbound for that entire week. So my GP then signed me off for a second week, and that second week I still couldn't get out of my flat. And then after that, my GP signed me off for a month. By the end of that month, I was still struggling. And in fact, at that point, I was having to walk with a walking stick. My GP then signed me off for a second month. And by the end of that second month, I was still incredibly symptomatic, but I started a phased return to work. So I was given what's called a 6 weeks period to slowly increase the duties, hours, and days that I was at work. I completed that phased return to work, and I have not been able to work full-time since. Since that, I now at best can work 4 days a week. I take a day off a week to pace my symptoms. But the long COVID symptoms that I have struggled with ever since have included severe fatigue or exhaustion. That's not the same as the type of tiredness that you may experience if you've had a busy week or you've been doing a lot of exercise. This is full body shutdown exhaustion. I have also had cognitive dysfunction, or what people have called brain fog, which is difficulty with processing information, short-term memory and concentrating, and sometimes reading. I've also had problems with my chest. So I've had problems with shortness of breath, and I've also got chest tightness, which is worse on exertion. And I've also got a symptom called post-exertional symptom exacerbation, which is that when I exert myself, whether that be physically, cognitively, or socially, my symptoms can be made worse. I mentioned that I had a crash in September. I've only just recently come out of another episode that if anyone follows me on Twitter may have seen, because I've been very public in my experiences, where about 4 weeks ago, I had another episode and my symptoms were all made worse again because of exertion. So including the changes to my smell and taste, the way that I think, my energy levels, my heart rate, my breathing, and also some neurological symptoms. So what's been clear from my personal experience is that long COVID came on unexpectedly, quite a long time after my acute presentation, and potentially was brought on by over-exertion. My long COVID symptoms have been multidimensional, affecting many different systems in my body. And at the moment, I've potentially got at least four different organ systems affected still because of long COVID. I still can't work full time. And my disability that I've experienced is not only unpredictable, but is episodic in its nature. I don't know what the long-term trajectory is of my long COVID, but I do know that overwhelmingly, my journey has been of improving, but has not been a straight line. It's been very up and down. And it's been much, much slower than anyone told us it would be right at the very beginning of this pandemic, which is we were all told we'd recover after a week or two. So I'm now over a year, 14 months after acute coronavirus, and I'm still navigating healthcare, and I'm still accessing diagnostics, and still trying to learn how best to manage my symptoms myself. So something I didn't say right at the beginning is I just wanted to say thank you for allowing me to speak in English this evening. I know that I can't speak any other languages, so I'm very grateful for that. But if anyone does have questions, you can ask them in the question and answer box in English, or you could also type them in other languages, and hopefully between the other people on the screen here, they might be able to support with some translation. So hopefully that's been a snapshot. And Loïc, I don't know whether you've got any thoughts having shared that personal story of long COVID.
It's quite like the big experience, and and that's really touching. And like we can see like the damage it can make on for someone to experience that through that long of time. What I was wondering is that you said that you are quite an active person, and often you say like it's helpful for it's helpful to not get sick, basically. And what are the risk factors who can catch like long COVID? Because we say that physically active person are more protected for this kind of sickness. But what is your point on that?
Yeah, it's a really interesting question. So I think to answer who is more likely to get long COVID, I think we need to understand what long COVID is. So I might start with that, if that's okay. So currently, the term long COVID is a term that was created by people living with the longer term effects after coronavirus. And the reason the term came up, it was created by an Italian lady, was because we were told originally that we would it was either going to be you got very sick, hospitalized and died or survived, or you didn't go into hospital and you recovered within 2 weeks. And what was clearly happening was people were still having lingering symptoms or longer symptoms. That's why the term long COVID came up. And in America, people were talking about long haul COVID and long haulers. At the moment, we do not understand what causes people to have ongoing symptoms after coronavirus. But we do know that there are many other diseases that cause long-term symptoms after infections, including other coronaviruses. We've seen that. We've also seen it with other infections, such as Ebola, Chikungunya virus, and many others as well. And so post-viral manifestations are not new. But what is new is this happening after SARS-CoV-2. We still don't understand what it is that virus is doing to the body to cause lingering symptoms. And so that's why there's lots of discussions about trying to use different terms and what different terms may mean. And at the moment, because we don't understand the mechanisms, we don't truly understand what causes long COVID is probably the most appropriate term, because it doesn't depend on any diagnosis or any certainty of the mechanisms of cause or outcomes. So at the moment, it's probably the most appropriate term, and it has been adopted by various different organizations around the world. However, what's interesting to note is that the World Health Organization are calling it post-COVID conditions. So in terms of risk factors, again, we don't really have a lot of answers about that as yet. What we do know is that there are some risk factors for acquiring acute coronavirus. So we know that there were some conditions such as diabetes and cardiovascular disease and being overweight that would put people at risk of acute coronavirus and severe outcomes of that. What's interesting is that when we look at the characteristics of people that have long COVID, it doesn't seem to mirror that with acute coronavirus. What we are seeing is that people can get long COVID irrespective of acute disease severity. So people that have been hospitalized and people that were never hospitalized can get long COVID. People that had mild disease can also get long COVID. And we've also started to see evidence that some people that were even asymptomatic in acute COVID can get long COVID. In terms of the characteristics of people, currently data is demonstrating that this is mostly affecting younger people. It's also affecting more women than men. Interestingly, the data demonstrates that more white people are affected, but we do not understand all of that yet. And I think there's a lot more work to be done as to what are the risk factors, what are the mechanisms, and also what's the long-term trajectory of long COVID, and who and why do people recover?
Another good question, I think, with that is how common is long COVID? Because basically, the pandemic has touched many millions of people. Yeah. How many people could contract long COVID?
Absolutely. So this is a really important question. And that's why if anyone's on Twitter, you will see there's a hashtag count long COVID. Now, probably the most accurate data to date has come out of the United Kingdom by the Office for National Statistics. And what they've estimated is that approximately 1 in 4 people after contracting coronavirus will still have symptoms after 5 weeks. So a quarter of people will still have symptoms after 5 weeks. They estimate that potentially 1 in 10 will still have symptoms after 12 weeks. And actually even more recent data is demonstrating that's potentially pushing to 1 in 7. But that's only 3 months. And what we know is that there are people living with long COVID that have had symptoms for 3 months, 6 months, 9 months, 12 months, and like me, longer. So the most recent data has estimated that in the UK, there are currently 1.1 million people living with long COVID. Now, obviously, each part of the world, different countries, regions, and settings have had different experiences of coronavirus, whether that be in terms of how many people have contracted the virus, how many people have been needed to access health services. But I think what's going to become increasingly more important is how many people that have contracted coronavirus are affected by long COVID. And I think there's a lot more work that needs to be done on how many people are living with long COVID, because we do not have global estimates of that yet.
So we know that we will have lots of people with long COVID in rehabilitation, so it can be a good thing to dive a bit more in this. And there are questions that ask you about your personal experience in that.
Sure.
And the first one from Michael is, and a good question too, is do you take any medication?
So I'm not currently taking any prescribed medication. So that's something that's given to me by a doctor. However, I am taking a whole load of supplements and self-medicating. Now, I'm not going to pretend that they have made a huge difference, and I'm not going to say that they are something that I would recommend. However, lots and lots of people are taking different supplements to try and help with their symptoms. There have been some things that might have helped me, and there are things that I've noticed that do seem to make a difference in terms of my symptoms. So, but I haven't been prescribed anything yet, although I have recently had an investigation, which is lung function testing, and I'm slightly anticipating, due to the results of that, that I may be prescribed an inhaler soon. Unfortunately, there are no medicines to treat long COVID. It would be lovely if there was, which is why at the moment, a lot of the approaches to try and treat or manage long COVID are not necessarily to try and treat the disease itself. It's to try and manage the symptoms that people are experiencing. So whether they be physical, mental, or emotional, or social health-related challenges, those symptoms that people are experiencing, that's where the approaches are coming in. And that's particularly why physiotherapists have become incredibly important in the care of people living with long COVID, because some of the symptoms that people may be experiencing can be managed by physiotherapists.
Let's talk about physiotherapy a bit more then. There are quite already a few questions about exercise. I think it will be the big topic tonight.
Always is.
The question from Julie is, in your course, you explained that exercises are contraindicated because of post-exertion malaise. What would you advise as a physio to help patient to recover? She means things that we can do with them in our practice.
Great, that's a really important question. So to be explicit about that point, in the course, we talked about some of the safety considerations, or maybe what we would call like the risk stratification, as to when physical activity, including exercise and sports, may require caution. And there were 4 things that are important. So there's that symptom of post-exertional symptom exacerbation, which is where your symptoms are made worse by exertion. So clearly, exercise is not going to make that better. And that's why we would say that it would potentially be contraindicated to force people to, or encourage people to push through their symptoms, because you're just going to make people's symptoms worse. The other things are potential cardiac involvement, exertional desaturation. So that's where people move and their oxygen saturations drop during or after exertion. And then also something called orthostatic intolerances or autonomic dysfunction. So some people might be having issues where when they go into upright positions, their heart rates go really strange and they become dizzy because of a blood pressure drop. So obviously that's a consideration if you're going to be encouraging people to be physically active and exercise. I want to be really explicitly clear with this. I'm not saying that universally physical activity and exercise is bad. What I'm saying is that we need to clinically reason when it is safe. And there are some people where exercise will work brilliantly for their recovery from long COVID. However, there will be people where it doesn't. And it doesn't work. And I fall into that category myself. And so the question, can you remind me what the question was asking? You're on mute.
What can we do in our practice to help these people?
So if people are experiencing exercise intolerance, so their symptoms are being made worse by exerting themselves, the best thing you can do is encourage people to stop, rest, and pace. Stopping implies not forcing through this, not trying to continue to push through your symptoms. Resting implies actual full-on rest. And I think I, as a physio, am rubbish at rest. And I think a lot of us are. When I say rest, I mean rest from physical, cognitive, emotional, and social exertions. So actual rest. So think mindfulness meditation, lying down and actually allowing your brain to stop. And then pacing. Pacing is a really, really complex, difficult topic. But in the stop, rest, and pace elements, pacing was probably one of the most important aspects that enabled me to recover from the disability that I was experiencing. So I would recommend that if people are experiencing post-exertional symptom exacerbation, or also known as post-exertional malaise, stop, rest, pace. And focusing on pacing is a really good strategy.
And what tool would you give to physio? That you speak about it a bit in your course in Physio Plus, but what tools can physio use to detect people that could crash after exercise and do post-exertional malaise?
Yeah, this is really difficult. So the first thing you can actually do is what's called like a narrative approach. So actually talking with your patients, learning what is going on with them, finding out the patterns of their symptoms and whether people are crashing or having episodes or relapsing. What is the trigger to that? What's happening? And often, if you start to look at that symptom profile over a week-long period, you can start to see those triggers and patients themselves will start to recognize it. There are some great apps that patients can use, and there's an app called Bearable app that can be quite a useful app for people to track their symptoms over time. There are other tools that can be used. So on the Long COVID Physio page in our resources section under post-exertional symptom exacerbation or malaise, which we can put into the chat box, there is a tool. There's a screening tool, which is it's a 10 question item questionnaire that screens for post-exertional symptom exacerbation or malaise based on the DePaul symptom questionnaire. It can be a really good way of allowing patients to explain to you what's happening with their symptoms. So that would be my first recommendations. Speak with your patients, find out what's happening with them, try to understand their symptoms and work together. And then from that, consider potential screening tools that may be useful, such as the post-exertional malaise screening item from the DePaul symptom questionnaire.
So there's the question about the DePaul questionnaire. So I did put a link in the chat. You can find every DePaul symptom questionnaire, the short version. I think
there's actually quite a lot. Yeah. So there's the original DePaul symptom questionnaire, which is enormous. It's like 60 items or something. Then there's a short version, there's a screener version, there's a pediatric version. The version that I'm talking about is a screening version, which is specific to post-exertional malaise. On the Long COVID Physio website, there's actually two images. They are the ones that if you click on those images, it actually takes you to the publication on those. And in fact, there's even a new tool that's just been published not recently, which is another longer tool specific to post-exertional malaise.
There is another question about your experience. It stays on the same subject because you spoke about pacing and resting. And the question is from Noemi, and it is: would you be or feel better if you could really rest for a long time, or do you need a certain amount of activity without getting over a limit?
That's a really interesting question, and thank you for it, because I think that is basically coming to the heart of what is pacing. So pacing is the balancing act between performing activities and purposeful rest. So for me, my symptoms are very fluctuating or episodic. And so because of that, I need to recognize my symptoms, see when I can feel like my triggers are being set. So for me, I know that my eyes start to get heavy. I struggle concentrating. I feel like someone has unplugged me and the energy is literally draining from my body, like a really old iPhone that just, no matter how much you plugged it in, just keeps losing battery. That's how I feel. And if that's the case, I know that I can't push through that and I need to limit my activities and rest more. However, when I'm not being triggered and I can feel that my symptoms are not there, I might be able to do more activities. So I think this is where it needs to be person-centered and individualized to the person that's experiencing these symptoms, but also recognizing that pacing needs to take into consideration and account for those fluctuations, and potentially having episodes where people may potentially have pushed too far and relapsed. And unfortunately, that is part of this journey.
And there's a question from Sophia that is, what were the main things that you feel have helped recovery for you? She has an example like type of rest, exercise. We know that it didn't work. But
yeah. So things that have not worked for me are exercise. Things that have worked for me has been stopping. So having that ability to be signed off work, to give me the permission to rest and learn to pace, was what helped me recover. Modifications of my duties at work, so that I was able to balance the types of activities, because as healthcare professionals, we work in different settings. And so if you have a fatiguing health condition that also affects the way that your brain is functioning, putting someone in front of a computer all day long is not necessarily going to be an easier task. So there was a balance between my duties. Also, another technique that worked for me was heart rate monitoring. So using a wearable, commercially available device, I've got an iWatch, to keep my heart rate below a certain threshold. That there are different ways of identifying that, but I figured out what my threshold was through monitoring, and trying to keep below that threshold. That was the trigger for setting off my post-exertional symptom exacerbation. So those are the things that have really helped for me. Some of my supplements have helped. Things like I take coenzyme Q10. I also take an antihistamine. I think they really help me. So yeah, those sort of things have helped. But I think the biggest thing that's really, really helped me has actually been peer support. It's the knowledge and skills of other people living with long COVID, and also other people living with other chronic health conditions that have shared their knowledge and skills, particularly people living with ME/CFS, that have really helped in terms of overcoming the emotional distress that's been caused by having such disability.
And I know you got vaccinated. There are quite a few questions on that. Did the vaccination help to improve your symptoms?
This is fascinating. Short answer is yes. So I was one of the lucky group of people that are living with long COVID that have experienced this phenomenon of improving. Now, I've had both doses of the Pfizer vaccine. I had my first dose of the Pfizer vaccine in January. Immediately, it caused a total relapse of all my long COVID symptoms. They all got worse. However, by about 3 weeks afterwards, I started to have a complete lift of all my symptoms. It was like a cloud lifted from my body. And the amount that I could exert myself, that threshold, increased. I then had my second dose in March. Again, a worse relapse this time of all of my long COVID symptoms, but only lasted 24 hours. Although I think it's unsurprising because a lot of people that have had the vaccine have had some experiences, maybe a bit of a dose of what COVID or long COVID feels like. I then had a huge increase quite quickly afterwards, where actually to a point, I had a month-long period of being completely symptom-free. However, it's not a cure because I have relapsed afterwards, and I have recovered after that relapse. I think what's interesting is my recovery time this time is much quicker. It's taken 4 weeks to recover this time, whereas last time it took 6 months. So there's still benefits, even if it's not a cure.
And do we know, that's a question from Miriam, do we know if people that got vaccinated could get long COVID or not?
Oh, that's a great question. And I'm presuming the question is specific to if people have been vaccinated but then acquire coronavirus. Is that right? So
I think yes.
Yeah, so this is a great unknown, right? So, you know, the vaccine scientists, the epidemiologists, the public health experts are still looking into that. But the key thing to answer that question is we must count long COVID, which still isn't happening across many countries or especially globally. So to answer that question, we must make sure that long COVID is on the agenda. But unfortunately, I haven't got an answer to that one. But it's a great question that needs to be answered.
So let's switch again to physiotherapy.
Sure.
That's a question that has the most upvote. So what do we do in physiotherapy to train with our patients? Should we do cardiac exercises, interval training? That's also an exercise. What do we know the best exercise therapy that we have?
Okay, so again, going back to kind of what I said earlier, we need to know whether physical activity, including exercise or sports, is going to be safe and effective. Currently, there is no evidence that physical activity, including exercise or sports, is safe or effective in long COVID. We have no research. So, in the absence of any research, we have to make sure that we are providing safe care. And to do that, there are those 4 things that there are a group of international collaborators that have come to the conclusion there are 4 things that potentially are worthwhile considering. Excluding post-exertional symptom exacerbation before considering or recommending physical activity interventions. Excluding cardiac impairment. So if your patients are having chest pain, breathlessness, really weird tachycardias, they require a review by a doctor before you recommend physical activity. But if they are reviewed and they're safe and they start a physical activity intervention, monitoring for delayed onset cardiac impairment, because we have seen that is happening. The third is exertional desaturation. Don't recommend physical activity to people that are desaturating on exertion. So if people's SATs are dropping by more than 3%, then that's abnormal and that requires investigation. So that needs to be done before you can start to exercise people. And the last is obviously the orthostatic intolerances or the dysautonomias. If your patient stands up and faints, don't exercise them because that's not going to work either. So I think as physiotherapists, we're very keen to get people moving. However, we're also very good at clinical reasoning and being safe. And I think we need to recognize that in the context of long COVID. Oh, you're on mute.
That leads us to the next question. That is that sometimes for young patients, some seem to deny the status they're in at that moment, and that makes it difficult to practice pacing with them.
Yeah.
What are your tips?
I concur. I was one of them. It's really difficult. Nobody wants to have a health condition and nobody wants to experience disability, especially people that have suddenly dropped after having a virus. People want to have their lives back. And so therefore I can completely understand why people may not be either associating with long COVID, may not want to limit their activities, and may struggle with not trying to push through. And I think what we've seen collectively in Long COVID Physio, which started as a peer support group of physiotherapists living with long COVID, is that all of us were really struggling with that. Because we all wanted to get back. We all felt that exercise could have been the magic cure, and we all tried to push through and we all suffered the consequences. You can't tell a smoker to quit smoking and they'll quit smoking because you've told them to quit smoking. A bit like you can't tell a child to do everything you want them to do. Adults are adults, and all you can do is you can work with people and educate them and support them through their journeys. And if people are really struggling with their symptoms and they keep crashing and they keep having these episodes and they're continuing to get worse, that's when the discussion about pacing will work. But certainly we can provide people with the information. And again, I'll reiterate, I'm not saying that physical activity is bad. We need to be physically active in our day-to-day lives. We just need to make sure that physical activity is not to the detriment of being able to function. So for example, I don't think it's appropriate that I force myself to go for an hour-long walk every day if it means that because of that, I can't get washed and dressed. So physical activity intervention should not be to the detriment of someone being able to function in their day-to-day life or their overall quality of life.
And you're a pretty big advocate for patients living with long COVID. And I think that you'll have experience with the next question. That is, do you have experience with patients who suffered from not being taken seriously with the symptoms at the beginning of the pandemic in March 2020?
Wow, thank you for that question, because it's really, really valuable. Unfortunately, yes, and not just then, but still now. I think there's so many unknowns about long COVID. We don't know what it is. We don't know what causes it. We don't know why people get it. We don't know how long people may have it for. We don't know if people will get better or why people get better or what can help people get better. So because of all of these unknowns, it's very difficult for healthcare professionals who often want to help and provide answers and make things better. And so I think a lot of the times, in the absence of that, healthcare professionals are finding it very difficult and patients are finding it very difficult because we don't have a lot of answers. Because of that, a lot of patients may be experiencing what's being called gaslighting, or where their experiences are being invalidated or not believed. My biggest ask of all healthcare professionals is to truly listen to your patients, believe their stories, and work with them. We know that developing what's called a therapeutic alliance, or that relationship between patient and therapist, is what creates the fertile grounds of a really good working relationship that makes your job as a physiotherapist better, but also the outcomes for your patients better, and the experiences that your patients have with you better. So the starting point of that will be listening to stories, validating people's experiences, and acknowledging that sometimes we haven't got all of the answers. And I think overwhelmingly we've heard that people living with long COVID are aware that there aren't all the answers and don't expect our clinicians to have them, but they do want to be heard and listened to and validated.
And I think that's an important question related to the patients too. Do we have any information about if there is a socioeconomic factor to the development of long COVID or not? Higher incidence in first world countries or...
Really interesting. So unfortunately, what we're seeing so far is that there are certain groups of people that appear to be living with long COVID, or at least are being counted as living with long COVID. What we are actually seeing is that it's predominantly women, predominantly white people, people that were younger, people that had good jobs, high economic status, and good education. So it's not going to be the traditional risk factors you're thinking about, but we must remember these are only the people being counted. There's probably going to be a whole group of people that aren't being counted, that aren't presenting to healthcare services, that have probably experienced either a whole range of inequalities in terms of healthcare, which can include systemic racism, marginalization, and misogyny that may impact on people's access to health services. And I suppose we need to consider that, but we haven't got an answer to that yet. But it again comes back to the point of why we need to count long COVID and do that epidemiological research to understand that in more detail. So hopefully we can find out what affects people. One thing we do know is that for people that acquired coronavirus, that then pushed through in the early phases, have experienced worse disability later on. And on the whole, those people are the people who could not afford to not go back to work, or were in jobs that meant they were going to go back to work and respond. So we're seeing that amongst healthcare professionals, teachers, transportation workers such as bus drivers and train drivers, and also people in maybe more lower economic jobs such as cleaners, people that couldn't afford to not be at work, whether that be through finances or the response to the pandemic.
There is Petra that asked do you think we can distinguish between the diagnosis of burnout and long COVID?
Yeah, I think we can. And I think one of the clear ways we can do that is that long COVID is a multi-system disease that affects organs, creates lots of different symptoms, and one of those symptoms includes fatigue. So I think possibly the pointed end of that question is, how do you differentiate between long COVID fatigue and burnout fatigue? Because I would say that that's going to be quite difficult to do. However, one of the key symptoms, such as the symptoms get worse when you try to push through them, is probably going to be the thing that differentiates long COVID. But I think it's really important. We have seen that there's a huge risk of burnout amongst healthcare professionals during this time. What's also interesting is that in the BMJ Leader, I was a co-author on a paper that specifically looked at the pandemic of both burnout and also of fatigue amongst people living with long COVID. So we can also put a link to that in the chat box, because that's a great commentary to read around that particular topic of both burnout and long COVID in healthcare workers.
And do you think it's correct or possible to be diagnosed with long COVID even if you felt perfectly well for more than 6 months after COVID-19 infection? If the onset of symptoms can start much later or not?
I was. So I had all of my long COVID symptoms started after 6 months. Or should I say, they got so bad by 6 months that's when I then couldn't work. I accessed my GP. So yes, I do think that long COVID is not dependent on how soon after acute coronavirus the symptoms develop. Long COVID in itself, as it still lacks consensus definition, is simply the definition of not recovering after acute coronavirus. And that again is not time dependent.
We'll make a pretty big switch now. From Leo. The question is, have you heard of the Belgian study that used tense stimulation on nervus vagus to help persons with long COVID? If yes, what do you think about it?
Interesting. So I have not heard of this study. However, I am collaborating with a group of people that are potentially looking at this type of intervention. So what we know is that some people living with long COVID are experiencing a range of different symptoms, and some of those symptoms can fall under the autonomic nervous system or a dysfunction of that. So simple anatomy, our autonomic nervous system, it's our automatic nervous system, comprises of two things, our sympathetic and our parasympathetic nervous system. So our sympathetic nervous system is the fight or flight one. It makes your heart rate go up, your blood pressure go up. It's the fast acting one. It prepares the body in response to strenuous physical activities. The parasympathetic is the rest and digest. So it also lowers your heart rate, lowers your blood pressure, relaxes your bladder, so you pass urine. What we know at the moment is that there are lots of people living with long COVID that are presenting with autonomic dysfunctions. The vagus nerve is part of the parasympathetic nervous system. So it's part of that rest and digest. One of the theories or a hypothesis is, could we stimulate the vagus nerve to increase parasympathetic nervous activity, to drive down heart rate, drive down blood pressure, to try and reduce some of the symptoms that people are experiencing? It's not new. It's been proposed in other healthcare conditions before. However, there's not a lot of research on it. So I think it's an interesting approach. Again, it's going to be a strategy to manage symptoms. It's not going to cure long COVID. But what I love about how the world has responded to this pandemic is it's brought people from many different aspects of science, healthcare, research, clinical academic practice, and academia together. And all of these new ideas are coming up as potential opportunities. And I think there are so many worthy things to investigate. And interestingly, that's one of them.
And if you talk about management, if someone doesn't have tools to use the heart rate monitoring, what would you do? How would you manage to do that?
Yep.
What's the strategy for that?
So obviously heart rate monitoring is dependent on having a heart rate monitor. So that is going to be dependent on a range of different things, such as personal resources, financial resources. Some people have allergies, for example, and don't want certain devices on them, etc., etc. So not everybody will have a wearable device or a pulse oximeter or a body strap. So there are many different things that people can do outside of that. And I think the biggest thing that people can do is monitoring their symptoms. Being aware of what your triggers are, being aware of how to rest, and also figuring out how to balance activities and rest, also known as pacing, is probably going to be something that's really useful. There are criticisms to heart rate monitoring as well as praise to heart rate monitoring. So I don't think heart rate monitoring should be seen as the only intervention, because one of the criticisms is that it encourages people to keep being hyper vigilant of their symptoms. But having used heart rate monitoring myself, I didn't find that I became hyper vigilant. I just quite appreciated knowing that I was going over and I needed to just have a bit of a rest. So yeah, and it doesn't work for everybody, you know, just like everything in healthcare, you know, like there may be interventions that work for some people, but not for others. So, you know, I don't think we should, I think we should be looking at the moment, how we might have a potential battery of options, a whole range of different options that we can use. And heart rate monitoring will be one of those options that may be useful for people.
For the other options of stress monitoring, Savannah is asking, what's your opinion on stress tests to measure a patient's level if it's a patient with post-exertional malaise?
When you say stress tests, I don't know whether that means psychological stress, like I'm stressed, or whether you mean physiological stress.
So I think the second one.
Got ya. So we know that in the UK, the National Institute for Health and Care Excellence, Clinical Excellence, NICE, and also the World Health Organization have recommended a couple of tests. One of those is a 1 minute sit to stand test. And the other one that's also proposed is a 40-step test. The purpose of those tests is that they've come from what's the word I'm looking for? Protocols that have been developed in pulmonary fibrosis or idiopathic pulmonary hypertension, and also COPD. They're not based specifically on long COVID, but the purpose is to see if people desaturate during or after exertion. That's the purpose of those tests. So if we're going to be using those tests, we also need to balance, is it going to be an appropriate test for that person? Do I need to assess whether a person is exertionally desaturating? So just like all of our tests, we need to clinically reason and use sound clinical judgment as to whether the test is indicated, whether the test is appropriate to use, and what are going to the implications be for the individual if we do that test. So for example, that test was done to me when I went to the long COVID clinic, the 1 minute sit to stand test. Unfortunately, the whole process of going to the clinic and doing that test is what caused my most recent relapse. So prior to that assessment, I was symptom free. However, I've just had a 4-week period of disability. And I'm just coming to the tail end of that now. So if you are going to do these tests, I would strongly encourage that you review your patients afterwards, not just at the time, because I think it's important that you understand the implications of those tests if you're doing them and understand the reasons why you're doing them.
So we know that you can be physically fit and get long COVID and have trouble getting better, and that is the link with the next question that is saying that a patient who used to be an excellent semi-professional cyclist after developing long COVID is presenting with normal lung function testing, but yet is very limited in cycling due to the feeling of not getting enough air. And how can it be?
So yes, long COVID can affect anybody, and being previously incredibly fit and well is not protective against long COVID. In fact, there's a whole Facebook group for athletes, including triathletes, who are living with long COVID. So in terms of why that individual is still breathless, I'm not going to be able to answer because I don't know everything that's going on. But we know that breathlessness can be caused by different things. So it can be caused by respiratory disease, or impairment, should I say. It can be cardiogenic in origin, but also there could be the neurocardiovascular component, such as how the autonomic nervous system affects heartbeat. And then also there are breathing pattern disorders. A recent study that came out on the Lancet demonstrated that I think it was 3, 6, and 9 months after hospitalization with COVID-19. So this is people still living with the long-term consequences and therefore long COVID, showing that diffusion of carbon monoxide in the lungs is reduced. So therefore showing impaired gaseous exchange. There are people talking about like happy hypoxias as well. So these are people that appear to be doing okay, but their oxygen levels are down. So if a person has had full pulmonary function tests, which included spirometry, as well as looking at the carbon monoxide diffusion, and also as well as looking effect of bronchodilators, which is a full battery of tests that needs to be ordered by a doctor and reviewed by someone that knows how to review those, then if there is still symptoms, it might be that they need to look at whether there's a cardiogenic origin or whether there's a dysautonomia or whether someone has a breathing pattern disorder, because that can also be something that can present later down the line.
And if you keep talking about exercise and people exercising, do you have any experience with exercises like Tai Chi or Qigong or body awareness therapies, since it's used for other conditions?
So again, I think this comes back to whether people can exert themselves. And I think if we look at exertion, So exertion includes physical movements. It includes me sitting here now on Zoom, cognitively engaging and answering questions. And it'll also include me socially engaging. So sitting with my friends outside in a park, having a coffee because we're socially distancing because of COVID. Those are all exertions. Different exertions will affect me in different ways depending on my symptoms. So I may feel fine to do Qigong one day, but I may not another day. For me, the key thing is about what are your symptoms, what are your triggers, and how are you balancing your activities and your rest. If those activities work for people, fantastic. However, they still could be an exertion. So I think if somebody is really struggling to function in their day-to-day life, whereby their exhaustion is so profound, they make a decision as to whether they get washed or dressed that day, or they can't make a meal, Qigong is not going to help that.
That might have a link with the, it's a question, but it's a person writing that he was healthy and active and contracted long COVID. That person suffered from fatigue and exhaustion, plus and concentration issues. And she followed the recommendations of rest, mindfulness, spacing, and now her body weight increased by 10 kilos. And she says, I am depressed about that, have hypercholesterolemia, and tendinopathy. Should I keep going that way?
Yeah, I put on weight too. It's unfortunate. This is really difficult, right? Because obviously, if we're all physically active before and we're not moving as much, there is a risk of putting on weight. For me, I need to balance what's going to help me recover. Pushing through did not help me recover and hasn't helped me recover. I don't know whether this person has experienced that or not, but certainly if that is the case, it's difficult to balance this. I think people living with long COVID are unsurprisingly experiencing mood and mental health related issues because of the level of disability that's being experienced. And I want to be really explicitly clear with this. Anxiety and depression does not cause long COVID, but unsurprisingly, because of the experiences and the impact that long COVID is having on people, people with long COVID may also have anxiety and depression. And I think that is where mental health services can help. I think making sure that we access those services at the right time to address and look after our mental well-being as well as our physical well-being will certainly help. So I certainly wish that person well. I really hope that they do get better. And I think that as many of us living with long COVID, we're finding that balance ourselves and struggling through. So it's not an easy one to answer.
Do you have any time left, Darren? Yeah, like
yeah, we can go. Yeah.
There is one other question that is quite related to exercise too. How effective are breathing exercises in patients with long COVID?
Okay, so breathing exercises are currently coming out as a part of a proposed rehabilitation intervention. So Mount Sinai is a hospital that has a centre in New York. The Mount Sinai rehab team there have created a bespoke rehabilitation intervention called Autonomic conditioning therapy. This approach is based on different approaches. So one of them is around the issues of dysautonomia that we've discussed before. And we mentioned earlier about trying to stimulate the parasympathetic nervous system. A way of stimulating the parasympathetic nervous system is through breathing techniques, through stimulating the vagus nerve. So they've combined that with also something called the Levine protocol, which is specifically to something, an orthostatic intolerance. So they combined those two to create a program, which is a long program over many months. And we did a podcast with this recently on the Long COVID Physio podcast with Jenna Tosto from Mount Sinai about this program. But basically, in a nutshell, it starts off with breath work to find stability and control of symptoms. And then from that, if stability is achieved and symptom control is there, building in supine, laying down exercises such as isometric exercises or range of movements, building up into upright, building up into aerobic exercises. However, it's not graded exercise therapy, which is specifically building up incrementally irrespective of symptoms. It's titrating the activities dependent on symptoms. So what that means is they only go to the next step if stability has been achieved and maintained. And if symptoms get worse, they go back a step. And I think that's a really important distinction here. So obviously, their data is demonstrating that they're getting some success in terms of people's fatigue. We need more data on that. We need more research on that. So we can't say it's going to be universally applicable to everybody, but the results are looking interesting. And certainly anecdotally, we're hearing that breath work is important for a lot of people. And actually, there's a group in the United States called Stasis that provide a free online breath work course that, again, you can access through the Long COVID Physio website. And that, again, is looking at supporting people that may have breathlessness, but also there's the added benefits of looking at like parasympathetic nerve stimulation. So there potentially is a lot of value in breathing exercises as such, or breath work, or whatever you want to call it. But I think we just need to bear in mind what it is and what it's about, which is it's trying to manage symptoms. It's not curing long COVID.
Let's go for a last one, I guess. So you have a bit of your evening. What kind of assessments would you recommend when diagnosing patients?
Oh my goodness. For me, I think this is going to be directed at physiotherapists. So there is currently no consensus on what long COVID is. So therefore, it's quite difficult to know about diagnosing long COVID. Different places in the world are going to have different processes, but certainly here in the UK, there have been attempts to try and get the coding done in our electronic health systems so that people can be diagnosed with long COVID, although there are issues with that, which is there are different terms also being used. I would say that as a physiotherapist, the most important part of the assessment is going to be listening to the patient's story, validating their experiencing, finding out what their symptoms are, identifying what the triggers are, looking at what's meaningful to the individual, and trying to establish that therapeutic relationship that enables you to work together. And if you can do those 4 key things of excluding post-exertional symptom exacerbation, cardiac impairment, exertional desaturation, and orthostatic intolerances or dysautonomias, then you might be all right to go out and do physical activity and exercise, and that could work for people. And if it does and it makes people better, brilliant. But be mindful of those 4 things and be cautious, because exercise and physical activity works for some people, but it's not always going to help everybody. And I think that's a nuance that I think our profession would do really well at acknowledging and implementing, which is that exercise works for a lot of things, but usually we've got the evidence to prove that. We don't have the evidence to prove that. And what's coming out is that people are relapsing and people are getting worse because of pushing through with too much physical activity or exercise. I can see you've still got a lot of questions, Loïc. I'll let you go for 2 more if you want.
So the most voted one is, how big a part of the symptoms like dyspnea, fatigue, palpitation do you think is peripherally induced, and how big a part is from central mechanism like maybe brainstem? Great question.
There's mounting evidence of the neurological basis to some of the symptoms. But we don't, as I said, we don't understand the mechanisms of long COVID yet. or in fact, really understand the mechanisms of post-viral diseases, such as ME/CFS. So I think that there could be central mechanisms, it could be peripheral mechanisms. It's really difficult to know. But I think if that research was done and identified those things and it led to potential treatments, whether those treatments were to manage symptoms or those treatments were to actually alleviate and cure things, that'd be great. But I don't think we've got those answers yet. But I think it's important to bear that in mind because obviously this is multi-system disease, long COVID, and neurological impairment is real. We are seeing people with peripheral neuropathies, with issues with the nervous innervation to various organs. So, you know, there are people talking about not having bladder control because of this. So, you know, losing their faculties and not having control over their bladder, as well as other problems with pain. I've had problems with my smell and my taste. It keeps changing. So when I relapse, my smell and my taste gets worse as well. So I've noticed that most recently. So there's clearly neurological things going on, but we just don't understand them enough yet.
So the last one I think will be interesting because I think there will be more of that in the future. Petra is asking because they did set up an outpatient long COVID group in the hospital, and she is asking if you have any experience with group settings and any recommendations. The pro, she says, are the peer profit from supporting each other. The contra is it's an heterogeneous group, diversity amongst clinical science and stuff like that. What is your opinion on
that? So my background is working in HIV, and I run a group rehabilitation intervention for people living with HIV that live with a multidimensional, unpredictable and episodic health issue. They're often very diverse in their presentations and have multiple needs. As an intervention, it provides exercise and education, and there is endless evidence that exercise is safe and effective for people living with HIV. We can't translate group rehabilitation interventions such as pulmonary rehab, cardiac rehab, falls prevention services, or pain management programs that, and just like my HIV rehab program, that combine exercise and education into long COVID, because we have no evidence on whether exercise is safe or effective for people living with long COVID. So because of that, I know that there are different groups that are being set up around the world, and what they look like is diverse. I think what you've said there about the pro being peer support is so valuable. And I think that's a great thing because actually we know that for many different groups of people living with health conditions, peer support has huge value and is both important in terms of quality of life, but also in terms of symptom control and also in terms of coping and managing uncertainty or worry about the future. But inevitably, people living with long COVID are an incredibly diverse and heterogeneous group. And so I don't think you're going to be able to provide a group rehab intervention that's going to be towards a very specific group or subset simply because that doesn't exist. And I think that's the case with many people living with chronic health conditions. You know, if you look at pulmonary rehab for COPD, they're all different as well in terms of the other health conditions that they live with. But I think if you're going to be providing group rehab interventions, I'm going to re-emphasize that point about physical activity and exercise. We do not have the evidence that it's safe or effective, and we need to be considering those 4 elements, and we need to make sure that as rehabilitation professionals, exercise is not something we just give people, we prescribe it. We are prescribing an intervention, and when we prescribe, we have to make sure that we're accountable for providing safe and effective interventions. So do make sure that your prescriptions of exercise are safe.
I think we're reaching the end for tonight. Do you have any any, I don't know, social media or stuff like that where people can join you or follow what you do, because you're pretty active in the middle of long COVID right now. It can be interesting.
Yeah, absolutely. So I would say that a really good starting place is our website, longcovid.physio, www.longcovid.physio. On there, we have a whole range of resources. You can look at all of the different types of work that we've done. We've collaborated with a whole range of different activities, such as research, academia, policy, and beyond. We've done a number of podcasts ourselves, but also collaborating on other people's podcasts. And also we provide peer support. So if there is anybody here that is living with long COVID, they're very welcome to join our group if they're a physiotherapist or also another allied health professional. Watch this space because this year, World Physiotherapy Day, the theme is going to be long COVID. As announced by World Physiotherapy. And also aligning with that, there is going to be a new briefing paper that will be published specifically about long COVID, physical activity and exercise. It will be published. Hopefully it'll be made available in different languages as well. So I would definitely watch this space for that. But if you want to find me personally, I'm on Twitter. I'm Darren A. Brown, and I'm very happy for people to make contact with me. And if people would like to, my DMs are always open. If you want to send me a message, very happy to engage.
So what is the last word you wanna say and pinpoint for the session today?
So I want to say thank you to everybody that's been here. Because as a person living with long COVID, obviously this is beyond personal. And I think I hope that that's come across. You know, I am a clinician, I am an academic, but I'm also a patient now. And certainly I hope that that has come across. If there's been any answers that have been passionate, it's because it's come from my lived experience as well as a patient navigating this. But I want to say thank you to the 182 people that have signed up to this tonight. I think it demonstrates how much people want this knowledge. And I don't know that I've got all of the knowledge. I've got some lived experience, and I hope that this has been able to support some people today with some answers and some information. But I would say that no one has all the answers right now, and no one is an expert in this field. There's people with lots of experience. So I would say keep an open mind, keep learning, keep being inquisitive as you clearly have been tonight, and just thank you so much for your interest in this topic, making sure that long COVID is on the agenda, but also that you will hopefully do what's right in terms of the safety and the support that you can provide for all of your patients, because they will be coming through your doors.
I think that's a great word to end to this workshop. I want to thank you for accepting and coming once again. And I want to thank everybody that came to attend. There were lots of questions. We're sorry that we couldn't answer all of them. Already like 25 or 30 questions, so that's already a lot. So maybe another time.
Maybe clearly there's a lot of questions that need answering. So feel free to continue this conversation on Twitter. So maybe, Loïc, maybe you could do a tweet and say, ongoing questions, ask them here. I'm very happy to do that if you want.
I can do that, no problem. I'll tag you on it.
Lovely, thank you.
So have a great evening, Darren. Thanks for everything, and good evening to everybody, and have a good night, I guess. Pretty late, so see you.
Thank you.